So because most often the patient is not sure of the date, it becomes unless you date the pregnancy, you cannot time the delivery, and unnecessarily you will end up in a false information of FGR or macrosomia. And CRL is the most accurate to the 5 days precision and 95% of cases. And if the CRL is more than 84, then head circumference is more reliable than the BPD. So advantages of early screening is early detection, exclusion of many abnormalities, early reassurance to at-risk mothers, earlier genetic diagnosis, and easier pregnancy termination if appropriate. So very often people can ask me, how long does it take for you to do a first trimester anomaly? I said sometimes even 30 minutes. The second trimester anomaly is much more quicker than a first trimester anomaly because we have to look at things in detail, and training is very, very important. There's an uncertain cost to benefit ratio, and sometimes late developments such as corpuscular agenesis, hypoplastic left heart cannot be detected in the first trimester of pregnancy. So, as per a very recent study by Nicoloids regarding diagnosis of abnormalities at 11 to 13 weeks, as you can see that in the first trimester, they're able to pick up around 30%. That's 1/3. You should be able to pick up in the first trimester of pregnancy. In the second trimester, almost 53%. In the third trimester, it's 14%, and undiagnosed, that is, which is diagnosed after birth, is 5%. So this you have to concentrate on the 30%, which can be diagnosed in the first trimester of pregnancy. So regarding the accuracy of ultrasound at 11 to 14 weeks of gestation of fetal abnormalities, it has got many abnormalities like crania and anencephaly has got 100% detection, 50 to 99% detections for cystic hygromas, DORB, gastroschisis, 49% for spina bifida, hydrocephalus, and 0% detection for corpus callosum agenesis and bladder extrophy. So the detection rate was almost 51%, and cardiac defects was 53%, because very often we have picked up cardiac defects in the first trimester of pregnancy with the accurate precision, as I will see you in the future videos. So first and foremost, what are the measurements which you will take in the first trimester? The first is to do the CRL crown rump length. You have to run NT. I'm not getting into the details. You have to measure the bilateral diameter and the head circumference. We know that the bilateral diameter and the HC is the largest true symmetrical axial view, where you can see the interhemispheric fissure. If you see this interhemispheric fissure, here is to show that it is not holoprosencephaly. You should be able to see, this is called the butterfly sign, where you see the two choroid plexus on either. Are you able to see my pointer, Dr. Radhika? Yeah? Can you see my pointer?
Yes, I can see the pointer, ma'am. Yes.
You should see the two choroid plexus. This should be visualized, which is called the butterfly sign. If you don't see the butterfly sign, then you have to think of a holoprosencephaly.
Okay.
And coming to we know that cranial bone ossification occurs by 11 weeks of gestations, and you will be able to see the lateral ventricles on either side, which is filled up by the choroid plexus. You should be able to see the cranial vault, and there should be no bony defects or distortion, and you must see the butterfly sign and document it in image that you have seen the butterfly sign, because people should not go back and tell you that you have missed a first trimester holoprosencephaly. So hemispheres should be symmetrical on either side, should be separated by an interhemispheric fissure. The brain mantle is generally thin and best seen anteriorly. This is a typical case of holoprosencephaly where you do not see the butterfly sign. And if you get a picture like this, it's a alobar holoprosencephaly. If you do not see the butterfly sign, it should be a holoprosencephaly. Corpus callosum and cerebellum may not be assessed, but I'll come into the details of further what all you can see. So as in the second trimester, we do in the axial plane, we do a transventricular, we do a transthalamic, and the transcerebellar. So likewise, in the first trimester, we do a transcerebellar, transventricular, transthalamic, and a transcerebellar. So in a transcerebellar plane, you will see, as I will show you in further future videos. So this is a transventricular. You see the intermediate fissure, you see the ventricles, which is filled up by the choroid plexus. Whereas in a this is a video of a transventricular plane, where you see the ventricles and the choroid plexus. Then coming to the transthalamic plane, where you see that this is the third ventricle, and again the two choroid plexus on either side. You should be able to see this in the first trimester pregnancy. Sometimes the third ventricle or the active this could be dilated. Keep it in mind. Do not make a diagnosis in the first trimester. Follow back at the at 16 weeks anomaly scan. So this is a transcerebellar, where you can see the developing cerebellum here, the fourth ventricle, and you can see the brain mantle. So these are the three planes which you must see and document in the first trimester pregnancy. And you always do a transvaginal ultrasound. Do not do a transabdominal. It is not worthwhile. You are likely to miss many abnormalities if you do a transabdominal. So this is a typical case of encephalocy, which is picked up in the first trimester. This you cannot miss, which is acrania. anencefali in the first trimester, is you can see a very hypoechogenic amniotic fluid in the first trimester, which is typically seen in acrania and anencephalus. So you should not miss anencefali in the first trimester. So if the BPD is less, what are the features of holoprosencephaly? One is when the BPD is less than the fifth centile. This is a normal looking brain with a butterfly sign. Whereas here there is no butterfly sign. It's a typical loss of butterfly sign, which is a holoprosencephaly. And you find a fused thalamus in the other pictures. Next, coming to the intracranial translucency. This is the normal intracranial translucency, which you see. As you can see here, the IT is completely obliterated. You don't find the IT at all. So immediately you have a look at the spine. Go back and look at the spine, and we found a meningomyelocele here. So when you find an obliterated meningocele, as you see in these pictures, one or two pictures, you will find a meningomyelocele, which is picked up in the first trimester of pregnancy. It becomes easy for termination. Coming to the eyes, you have to look at the eyes with the lenses, the interorbital distance, and the binocular distance. When it is more than 95th centile, think of hypertelorism. Less than 5th centile, think of hypotelorism. And they're all features of 13, 18, 21 and frontonasal dysplasia. So these are the few things which you see in the first trimester: the nasal bone and the premaxillary triangle. This is the PMT. As you can see, it's triangular in shape and it should be intact. If it is not intact, then you have to think of a cleft palate or a cleft lip. And this is ideally done only in the first trimester of pregnancy. You can see the nice PMT there. So this was a case of micrognathia picked up in the first trimester. Look at the nose, mandible, and the lips. This is the cystic hygroma, which is again picked up in the first trimester. This is a huge cystic hygroma for the hydrops. This patient, we did a CVS, tested positive for trisomy 21. This patient tested positive for trisomy 18. And you will find bilateral jugular lymphatic sacs. And all this should be done in the first trimester of pregnancy. We had a patient of recurrent cystic hygroma at 12 weeks. So this patient came at 10 weeks saying that just see whether I have a cystic hygroma or not. So that is nowadays the awareness among our people. Then coming to the chest. Once you finish the head and the neck, the chest, the lungs should be homogeneous. You should not find any fluid. The ribs should be normal in length and shape. So this is a case of bilateral pleural effusion. Always look at the diaphragmatic continuity. If you do not find the diaphragmatic continuity, diaphragmatic hernia is ideally seen in the, you can pick up a diaphragmatic hernia in the first trimester. You should be able to see the diaphragmatic continuity. And if you do not find it and you find the stomach bone and the chest, think of a diaphragmatic hernia. Next, coming to this is the normal position of the head, the normal position of the heart. On the left side, always, you must do a cyclis in the first trimester also. Make sure the stomach and the heart are on the same side. Assess the cardiac axis, the regular activity. This is the four-chamber view. If you've seen this four-chamber view, you are rest assured you have two inflow tracts. This is the arch view. It means that the arches are normal. That is, the three-vessel view also is normal. So most probably the patient will not have a cardiac anomaly. So the stomach and the heart should be on the same side. That's the left side of the chest. So this was the case of hyperplastic left heart. You don't find the left ventricle at all. You don't find the aorta. The aorta is completely no atretic, and you find the reversal of ductus venosus. When you find the reversal of ductus venosus, look into the heart thoroughly. You will find an abnormality. So you have to be very, very, very sure when you have a reversal of the REDF, go back to the heart and look into it very, very clearly. So this was a case of AVSD, which is picked up in the first trimester. There's a VSD there. You find a halo. There is no situs. So this is the empty space, which is where there's no highness. And this is a typical AVSD, which is seen in the first trimester of pregnancy. So the VSD and ASD and central, the site is, you don't find the crux of the heart at all, which is typically seen in AVSD. So this AVSD, when you put a color, you will find an inverted Y. When you find inverted Y, it means that the blood is flowing from the atrium into the ventricles simultaneously in the form of Y, which is typically seen in a AVSD. So if you find a Y sign, then it is a case of AVSD, and you have to be very careful. The baby was moving a lot. We had a lot of difficulty in taking a video. And this is a case of double outlet right ventricles in the first trimester. Can you see two vessels arising from the right ventricle? So two parallelly placed vessels, which is picked up in the first trimester. This is again a color flow where you can see two vessels arising from the right ventricle, just DRV. This patient, we did a CVS and it turned out to be a trisomy 21. This was a very interesting case. This patient was referred for pleural effusion, the bilateral pleural effusion. Can you see the diverticulum? This is at the apex of the heart. You can see a small space there, which is a diverticulum of the heart, causing the bilateral pericardial effusion. This was a color picture. You can see the color flow arising from the ventricles into the diverticulum. This is the color flow which is getting into the diverticulum. It's very, very rare. This patient opted for termination of pregnancy in spite of a repeated counseling that most probably the fluid vision will regress. She didn't want to have she wanted to have a termination and she terminated. And coming to the spine, yes, this you must get a good sagittal view of the spine, a coronal view of the spine, because if you are playing with the vertebra, you have to think of do a thorough imaging so that you will find a small spina bifida there or in a meningomyelocele. Always document the intact overlying skin. So diagnosis sometimes may be difficult because of small lesions. This was the case because lemon and banana sign was absent. This was the case of acute kyphoscoliosis. Once again, this patient tested positive for trisomy 18 following CVS and she went for termination of pregnancy. So this was a kyphoscoliosis. As you can see, acutely the spine is angled and so it was very case which is picked up in the first trimester of pregnancy. So markers of spina bifida, crash sign, parallel place, when peduncles, when you have increased brainstem tops up at distance. When you find an obliterated intracranial transverse, think of spina bifida. And lemon and banana sign was generally seen in the second trimester, was absent in the first trimester of pregnancy. So coming to the abdomen. So what all can you see in the abdomen? You have to look at the upper abdomen, the mid abdomen, and the lower. So in the 1 minute. In the upper abdomen, you should see able to see the stomach bubble, you will see the kidneys, and you will see the bladder there. So in the upper abdomen, make sure that the stomach is on the left side. Have a good look at, you should see the stomach bubble, right-sided liver, the descending aorta, IVC, and you can also see the cord insertion, the umbilical vein can be picked up in the upper abdomen. Then coming to the mid-abdomen, you should find a normal cord insertion there, intact abdominal wall. This was the case in omphalocele, picked up in the first trimester of pregnancy. Patient again went for termination of pregnancy. Look for ascites. In the lower abdomen, you must look at the bladder. The bladder should be visible. It should be less than 7 mm. And when you apply the color Doppler, you will find 2 umbilical arteries. So you can exclude single umbilical artery in the first trimester of pregnancy. And you can also assess the renal arteries in the first trimester of pregnancy. So this was the case, a normal case of bladder. You can see the bladder and the kidneys there. The fetal kidney should be seen as paraspinal location as vein-shaped echogenic structures. The fetal bladder should be visualized. It should be less than 7. If it is more than 7 to 15, the risk of aneuploidy is 25%. More than 15, the risk is about obstructive uropathy. So this was a piece which is pelvic ulcer separation seen in the first trimester of pregnancy. This is a very interesting case of polycystic kidney in the first trimester. This patient had an encephalocele and she tested positive for Meckel-Gruber syndrome. So this was again detected in the first trimester. See, I think 1/3 of the anomalies can be picked up in the first trimester of pregnancy. And this was a case of megacystis bladder. You can see the huge bladder there with bilateral hydronephrosis and echogenic kidneys. So now coming to the extremities, you have to look at the bony segment of the upper and the lower limbs, normal orientation of the foot. And you must make sure that you see this orientation of the foot. Look at the hands on each side. It's easy to look at the hands and feet in the first trimester of pregnancy. And try as far as possible to count the phalanges, which is much easier in the first trimester. Clubfoot can be picked up in the first trimester of pregnancy. So this was the case of absent femur, absent tibia, fibula, and clubfoot, which was picked up in the first trimester of pregnancy. And this patient had a skeletal dysplasia. Can you see that? And these are the normal limbs which you can see, but this patient had a absent femur and a clubfoot, and this patient tested positive for a lethal skeletal dysplasia because she had a recurrent skeletal dysplasia. Once again, the femur was very, very short and she had a clubfoot. And once again, we tested for skeletal dysplasia, which showed a pathogenic mutation. So this again is a very, very short femur, which is seen in the first trimester of pregnancy. You have to do a measurement of the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. And you have to do all the 4 measurements. Otherwise, you will miss out cases of small extremities. So you have to look at the extremities in detail, look at both the upper limbs and the lower limbs, the humerus, radius ulna, the femur, tibia, and the fibula, and the spine. You can see the spine beautifully here in this video. So this was a very interesting case of conjoined twin, which was picked up at 8 weeks. And it was a thoracopegus. You can see the sharing of the heart between both the fetuses. And after expulsion, this was a picture which was seen. The consultant was kind enough to send me a picture of the conjoined twin. So even at 8 to 9 weeks, you can pick up many anomalies. I'm not going into details of 8 or 9 weeks. So ideally, I think we will set the limit at 12 weeks of gestation and see what all we can pick up at 12 weeks. So this was a typical conjoined twin which is seen at 8 weeks. So what all on the head you can see present cranial bone, head is present, cranial bone, midline fox, choroid plexus, normal appearance of the head, eyes with lens, nasal bone, normal profile, intact lips, vertebra, intact skin, and no effusions. We have a checklist which should be ticked after every ultrasound. If we miss out on anything, we tell the patient to come back. Suppose we don't find the bladder, even after say 1 hour of scanning, patient is very impatient. Tell the patient to come back after 2 weeks to have a good look at the bladder. If you don't see the stomach also, the same thing applies. Cardiac regular activity, four-chamber view, abdomen, you should see the stomach, the bladder, and the kidneys. Normal cord insertion, extremities, all the 4 limbs with 3 segments, placenta, and 3 vessel cord, whether it's 3 or 2 vessel cord. So safety is very safe. VM mode, M mode is safe. Doppler is great energy output, therefore more potential bioeffects, can be easily used in pregnancy. And something which cannot be picked up in the first trimester is corpus callosum, Dandy Walker malformation, and evolving skeletal dysplasias, and some more hard defects. For example, something that tetralogy you can pick up. Hyperplastic left heart sometimes can be picked up, and many anomalies sometimes cannot be seen in the first trimester of pregnancy. To conclude, checklist is mandatory with documentation, should not replace a targeted scan. Even if you do a thorough first trimester ultrasound, you must repeat the target anomaly at 20 weeks. When in suspicion, when anomaly, get a second opinion. We have had many patients of clubfoot, which we've seen in the first trimester. We've made a note saying that there's a clubfoot come back at 16 weeks. And very often I've found that the clubfoot will get corrected with 16 weeks. So don't label, just give a suspicion of a clubfoot. Tell her to come back if you have a doubt at 16 weeks before making a diagnosis, especially in CNS anomalies. Because very often I get pictures of many patients, ultrasound done at 8 weeks, the brain looks not abnormal and things like that. So never make a commitment at 10 weeks. Call her back at 12 weeks. Still have a doubt, call her back at 16 weeks of gestation. Thank you. Thank you very much for your patience here.
Thank you, Dr. Amala, for a nice and crisp talk. And I'm happy that I was able to make out this conjoined twins recently in 2 cases.
Yes, ma'am.
Subsequent weeks. Okay.
Yes,
so
ma'am.
the thing is that eyes cannot see what the mind does not know. So keeping
Yes.
what you said in mind, if you look at the scan, definitely we will not miss anything, any abnormality. At least you can get a second opinion once you think
Correct,
that
correct.
something is abnormal, so that we can give the best to the patient. Thank you very much.
Yes.
Nice.
If you
Amala?
have a doubt, always
Ah,
get a fetal
Thank
medicine
you.
opinion. So it
Thank
becomes
you,
easy.
Maladi,
Not
for your
only doubt,
excellent
madam.
what I feel,
presentation.
Malati, whenever
Yes,
once
ma'am.
you make an abnormality, it is always safer to get an expert opinion before termination
Correct.
for a
Yes.
legal aspect
your
also, isn't it?
audio பண்ணுதான்னு பாரு.
Yes, ma'am.
Amala?
Thank you,
Ah.
madam.
Good evening to everybody. Thank you, Maladi, for giving an opportunity to be a part of this program. Actually, you are like Vande Bharat, very fast, very, very fast. But actually, I don't do this first trimester scan. Always I refer to the sonologist because Aragara knowledge litigations are more with the patients, you know. Sometimes lethal, if it is not even lethal, we are not able to convince the patient attenders. They just, if you tell something, some anomalies, then they want to have the
Yes, ma'am.
termination
See,
of
that's what
pregnancy. So
even in fetal
what
neuro
to
training.
do, how to manage those patients if they want termination. Suppose any cleft foot also, if you say that
Yes,
they have
yes.
got this cleft palate, something like that, small thing, we can be corrected. It's very difficult for us to manage them. So what to
Correct,
do,
correct.
how to document that, and whether we can get a second opinion and then also talk to them or convince them what to do with those patients.
Sometimes a clubfoot can be because of position, madam. So make a suspicion of a clubfoot, call her back at 16 weeks of gestation to confirm. And very often, even when we say that this baby is abnormal, they immediately go and terminate. For example, this diverticulum, I said, wait for a while. We'll do a pericardiocentesis, remove the fluid, wait, because it's likely to regress on its own. But this patient said, nothing doing, I'm going for termination, and she terminated. So many CNS anomalies, even though we have a suspicion, we mentioned in the report, but we do take a final call at 16. We always tell the patient, this is just a developing brain. You have to wait for the structures to appear. When you find a dilated fourth ventricle, there is a possibility of Dander Walker, possibility of post anomalies. So we immediately do not make a diagnosis, because even Mallinger says don't make a diagnosis in the first trimester, especially CNS. Call her back at 16 weeks and then make a diagnosis at 16 weeks of gestation, and do not alarm the patient that, corpus callosum is not seen, the pericallosum flow is not seen. No, don't do such things, he says. If you have a doubt, always 16 is the early anomaly scan is ideal, madam.
And then most of the cases, they give us hypoplastic white dots in the ventricle. So review after 2 weeks. So what does it indicate?
Even echogenic focus in the left ventricle.
Echogenic foci in the left ventricle.
Isolated
nothing to worry.
echogenic focus, leave it.
Yes, nothing happens. Nothing happens, madam. The down screening has been normal. Suppose we should had a combined test which is normal or a quadruple which is normal, we can just leave it alone. But always, madam, usually what we do is we leave the option. We tell them that 99% this baby is likely to be normal. 1% we don't know, could have down, because we had sporadic case of echogenic focus having downs. So always leave the option, put the ball in the patient's court. If they are willing to take the 1% risk, fine. You don't have to do further investigation. Suppose you don't want to take the 1% risk, we will do an amniocentesis. But most often deny an amniocentesis. But some patients are very particular. They say, no, we want to know 100%. Then in such cases, we counsel them in such a way that we give options and let them choose. Even echogenic focus, I will not say the 100% this fetal is going to be normal. There is a likelihood based on the risk. For example, the risk can be 1:600. So we'll say out of 600, one baby is likely to have downs. So that will be 0.5%.
So better to
always it's better to discuss the options and then let them take a call.
If it's an echogenic, it could be a normal variant. Do you advise a fetal echo then probably?
Yes, ma'am. Fetal echo is ideal. We have to do fetal echo.
If it's an IVF pregnancy, Dr. Malti, the dating scan, how do you give?
What is the gestational age?
Based on CR. Based on the CR.
No, the dating scan, would you look for the embryo transfer date and then you give your expected date of delivery?
We do the ET date. We have a software, whether the ET blast or day 3 or day 4 embryo, and based on that, we just put the date of conception and we get to the user EDD, which is done. So we don't take the LMP in IVF patients. The strategy is entirely different. We don't do the LMP. We do the date of transfer. And for example, donor embryo, then we put the age of the donor. Age of the donor. We don't, because if it's 45, we'll automatically get a higher risk. So always ask for the age of the donor. It's done very confidentially. Talk to the consultant in confidence, ask them what is the age of the donor. So based on that, we don't even ask the patient, because patient is not aware of the donor or age. So the consultant is directly contacted and we can.
What we do when we are filling the form, we ask the patient if it's okay to fill up the donor's age, because they have to also give us a consent that it's
an consent. Very often patients are not comfortable. Initially, we used to ask the patient, but they're not comfortable when we ask them about the donor egg. So we stopped asking and we talk to the consultant directly and get information regarding donor egg or the donor sperm, whatever.
Suppose if you have a short female length, around 12 weeks, like less than 5%, how do you go about such patients? Like, would you really document it then?
Yes, definitely we will document it, ma'am. If the female length is less than 5th centile, we look at the other long bone, for example, the humerus, and everything is falling below the 5th centile. We don't label it as skeletal dysplasia. We call them back at 16 weeks. Do a complete survey, look at the CC circumference, look for any facial dysmorphism, look at the phalanges, look at the feet, and then take a call. We don't immediately, for example, this patient, the picture which is showed, the femur absolutely no, it was hardly measuring around 2 mm. Such patients, we had to make a diagnosis of skeletal dysplasia. The centile was not coming at all. And she had previous 2 skeletal dysplasias not investigated, just terminated. So this patient, I said, nothing doing, you're doing a series, I'm finding out the reason, only then you can terminate. And she showed, I think, short limb dysmorphism or something.
I had a patient who was referred me with a short femur. She was advised termination. The patient refused and came to me. I counseled her and she was worried. If it is going to be a girl baby with the short legs, then how am I to go about it? So I want termination. Then I counseled her and
girl baby,
delivered normally.
I have got
the general rule is, madam, if it is less than the 5th centile, the possibility of IUGR is high. If it is less than the 1st centile, the possibility of skeletal dysplasia is high. That's how we categorize. It could be IUGR, because if you follow back after 2 weeks, you. Yes, ma'am.
I have got one patient. At present, she is having checkup with me, and then Down's positive. She was got trisomy 21 something for this we did. She didn't do that double marker. So we have to do the triple marker at 20th week. And then it's positive. So I didn't know what to do because IVF was done for her. And then I spoke to the husband now that she can have an amniocentesis. Then he was laughing and telling me that this lady is 43 years now. Then he told me that the eggs are donor eggs. So that girl is 23 only. So then you can leave it, madam. You need not worry about. He convinced me in this case. So
Sometimes we don't know. We find even down to the age of 18. We found the youngest age was 18. So in such case, if you have a doubt, you can do an NIPT, madam. We don't have to do an invasive test.
But
Today we had a 15-year-old patient with pregnancy.
The lady didn't know that she had been given an IVF with a donor egg. So she didn't. Yeah, that is the thing. We are not able to get the true history from the patient also. Oh.
Yes. Sometimes the consultants give us a message. The thing is saying that keep it confident. This patient had a donor. So such things can be usually give a private message to us so that we don't ask the patient at all. We just mention it.
Okay.
But I think we should inform the patient who received the donor eggs, right? We can't do it without informing the patient.
Important. Now with the ART rules, it's I think dangerous to do it without information.
What is the gestational age we should subject the baby for fetal echo? No, fetal echo. Nowadays the government wants the mother as well.
Ideal 20 weeks, madam. Ideal is 20 weeks.
20 weeks. Okay.
Yes.
Fetal echo.
Suppose we find a small VSD. Very often we find a small VSD in first trimester. Then we call it at 16 weeks. So depending on the first trimester scan, everything is planned. But ideally 20 weeks, madam.
Should we recheck the anatomy that even in the late trimester, Malti, like around 30 to 32 weeks when you're doing another growth scan? Is there any evolving?
What we do is generally, if she had a first trimester anomaly with us, we just do the measurements. But if she's coming for the first time for a growth scan, we do a complete anomaly scan with the face, heart, spine, everything is done in detail. But if she's already had an anomaly scan with us, but of course we look at the spine, kidneys, on the head, everything is done. I mean, we have a checklist about 6 or 7, which we've seen in the third trimester. But
Is there any
evolving
anatomical problems where you see it in the late trimesters? The cardiac anomalies or anything?
Many, ma'am. We find a lot of hydrocephalus, short bones, diaphragmatic hernias. Because diaphragmatic hernias, it's evolving things. And the stomach bubble is below the diaphragm, it's normal. Unless you find out with the left axis deviation. So we found diaphragmatic hernias at third trimester pregnancy, short bones, hydronephrosis, that can appear in even megacystic bladder.
I had agenesis of corpus callosum at 32 weeks. She had regular scan with an expert scan, sonologist. Is it that it was missed or it was first diagnosed only at 32 weeks, sir? Because
we have to see it
regularly I regularly send to the expert sonologist only.
But only seen at 20 weeks, madam. 20 weeks.
It should have been, yeah.
What about small? Suppose the CSP is very small or very thin, then definitely a neurosonogram is ideal. Because very often we get CSP is very small, and we do a neurosonogram, we found a CC dysgenesis, corpus callosum dysgenesis. So ideally at 20 weeks, you should be able to pick up. Depending on the yes, like 12 weeks.
Gastroscopy. Okay. The polyhydramnios, lots of patients diabetes and polyhydramnios, they come and sometimes they don't, it is diagnosed very late at 34 weeks.
Yeah.
And then
sometimes it happens. They come for ultrasound, we find polyhydramnios. We tell the consultant, maybe looks like a diabetic and they know only GTA. They find diabetes. But I think nowadays we do it at booking, so that diabetes should not get missed out.
Okay. Thank you, ma'am.
Thank you, madam.
Thank you, ma'am.
To the next.
Okay, ma'am. Thank you, ma'am.
Amala, please. Amala, can you introduce the speaker? Speaker CV, please.
Yes.
Dr. Uzma, MBBS, DGO, DPN, BMR, COG, Fellowship in Fetal Medicine, So lead consultant, fetal medicine specialist at Ashoka Medical Hospital, Nasik, Maharashtra, specializations, fetal echocardiography, fetal neurosonogram, amniocentesis, chorionic villus biopsy, and fetal reduction. Dr. Uzma?
Yes, ma'am.
Ah,
Good evening,
Hi,
everyone.
Uzma.
Hi,
Good
ma'am. Good evening, Malti, ma'am. How are you?
Yeah, good. Thank you. Uzma used to work in my center, ma'am, for almost 6 months. Very dedicated fetal medicine specialist, I would say.
Nice, nice.
Ma'am, can I share my screen?
yeah.
Ma'am, is my screen visible, ma'am?
Yes.
Yeah,
Yes,
yeah,
yes.
yes. Yes.
Okay, good evening, everyone. At the outset, I would really like to thank the TNF OG for giving me this opportunity and to be a part of this esteemed panel today with my mentors, Dr. Malti ma'am, Dr. Sinish sir, and Dr. Punmuri ma'am. I'm Dr. Uzma, and after Malti ma'am's Rajdhani Express talk on the first trimester checklist, wherein you had so much of heated discussion of how to diagnose, where to diagnose. Means ma'am has gone to 8 weeks. Also, she's running against the embryological clock for diagnosing the anomalies. So I guess it's time to take some breath because all your heart must be pumping very fast after seeing mind-boggling anomalies. So I'll be talking on the topic, screening for aneuploidies made simple. So the main word is made simple. So today I'll be trying to talk to you about screening with more of facts and less of figures. So basically, when we talk about screening, what are we trying to do? We are trying to accurately assess the risk of the baby having any chromosomal problem. But while ascertaining the chromosomal normalcy of the baby, we also have to take into account what are the inherent risks of miscarriages if we push our belief very far. Also, try to understand what are the individual expectations of the couple from you. Hence, as a clinician, it is our responsibility to give them the actual facts and not just arbitrary cutouts. We, as a fetal medicine specialist or OGIans, are always worried about missing on to some serious rare anomalies or chromosomal abnormalities. But the word screening mainly stands for screening chromosomal anomalies like the Down syndrome in the general population. So to begin with, what are basically aneuploidies? Simple definition, an abnormality in the number of chromosomes in the cells due to loss or duplication. Why do we screen Down syndrome to be in specific? 1 in 300 pregnancies are known to cause or known to have chromosomal abnormalities. 95% of them will be trisomy 18, 13, and 21. 1 in 200 pregnancies are known to have Down syndrome. And 90% of the affected mothers are going to be young. So when so much is the incidence of Down syndrome, why not just stick in the needle into every mama's tummy and find out and have a diagnostic test? No. That is going to increase your background risk of terminations and abortions. So the general policy is you try to screen for all. Let us have a brief look at the brief timeline of the screening history. In 1960s, maternal age was being used as a modality of screening. As we moved ahead, in 1980s, maternal serum alpha-fetoprotein and thick nuchal fold came into the picture. We still progressed and we came to the triple and the quadruple marker. In 1990s, with the advent of the historic paper by Kypros Nicolets, nuchal translucency, along with the PAPE and beta HCG came into picture. Of lately, NIPT advented into the market in 2010 to 2011. And now you would even have medical reps coming to your clinic and assuring you that there is a form of extended NIPT where you can get not just these 5 major chromosomes, but also some micro deletions. We have to basically understand what is the ultimate goal of our primary screening. So, universal aneuploidy screening should be recommended. Screening should be offered and not ordered, and that too with adequate pre-test counseling. Just brushing up some basics. What are the technical standards and guidelines for prenatal testing? Specimen collection and transportation, very important, because that is one thing which is not in our hand. So specimen collection, we either use the whole blood serum or the dyed blood or the dried blood spots, which is being used. The advantage of dried blood spot is it is less invasive and easy to transport, but it does affect the level of performance of PAPE and beta HCG. Specimen transport for serum and the dried blood both have to be done at ambient temperature. The stability of the maternal serum markers of the blood before it is analyzed is very important. We all should remember that beta HCG is highly labile and even unstable at ambient temperature. Hence, most prenatal screening procedures or tests, they measure the intact HCG. The recommendation says that you either centrifuge the sample, separate the serum, and then you can store it to at least a maximum extent of 6 to 7 days at 4 degrees Celsius. Pre-test information, really very important, and what all you need to tell. That it is a screening test and not a diagnostic test. What all are you screening for? Patient awareness that we are screening for specific chromosomal disorders is really important, and that we are not going to look at all the chromosomes in the body. What if tested positive? If tested positive, we definitely need a confirmation. And how do we do that? We do that either by a chorionic villus sampling or by amniocentesis, and hence the cost, the pros and the cons of the procedure really need to be taught to the patient. Along with that, the risk of pregnancy loss has to be emphasized. Of course, in expert hands, the risk of the pregnancy loss is really low, but definitely awareness is must. And once you've been diagnosed with any aneuploidies, there is no intrauterine treatment which is available. We all need to be aware of the MTP amendment which has taken place in March 2021, wherein the termination period has been extended from 20 weeks to 24 weeks, where at least 2 doctors would believe that the pregnancy involves a substantial risk to the mother or the child, or if there is a substantial risk of fetal abnormalities. I'm sure many of us have been faced with this situation. Pregnant mama, she's thinking, ultrasound, chorionic villus sampling, maternal serum testing, cell-free fetal DNA, no testing, amniocentesis. What to do? Let me take you through the journey. First, let us discuss something about the first trimester serum markers. These markers are generally fetal or maternal products. So in first trimester, we have our HCG, we have our PAPE, alpha-fetoprotein, PLGF, and inhibin A. And the markers which have been dealt in the second trimester are HCG again, along with alpha-fetoprotein, unconjugated estradiol, and inhibin A. These factors are divided as placental factors and fetal factors. Placental factors being beta HCG, PAPE, and inhibin A, and fetal markers being maternal serum alpha-fetoprotein and unconjugated estradiol. Let us have a look at the ultrasound marker. So the first trimester USG markers are nuchal translucency, nasal bone, tricuspid regurgitation, and ductus venosus. As we all are highly affiliated with the FMF guidelines for the nuchal translucency, so I'll quickly brush with them. For NT measurement, it has to be an exact or a true mid-sag between a CRL of 45 to 84 millimeters. Include the upper head or the upper thorax. Fetus should be in the neutral position. Always distinguish between the fetal skin and the amnion and measure the maximum NT thickness. The placement of caliper is also very important when it comes to measure the thickness. Nasal bone, we are mainly trying to look for unossified or delayed ossification. 1.4% of chromosomally normal fetuses may have absent nasal bone. 65 to 70% of the fetuses with absent nasal bone belong to the cadre of trisomy 21, 50% to the trisomy 18, and 30% to trisomy 13. Ductus venosus. 80% of the babies with ductus venosus abnormalities are known to have any cardiac problems or chromosomal problems. 5% of fetuses who are normal can have ductus venosus problem. A reduced forward flow and a higher PI is also of a lot of importance and not just a reversed flow. Ductus venosus is an independent marker in itself. For imaging, we try to image the baby in the mid-sag in the right ventral view. Ductus venosus is being located on the color flow mapping, keeping into account the thermal index because we are using color Doppler in the first trimester. The gate size should be 0.5 to 1 mm because it's a very small, tiny structure we are trying to measure. The filter should be low. The sweep speed should be around 2 centimeters per second, and the angle of insonation should be less than 30 degrees. Tricuspid regurgitation. It is taken with the heart in the apical position. The gate size should be at least 3 to 4 millimeters so that it covers both the sides of the valve. The limit of tricuspid regurgitation has been set at 60 centimeters per second, beyond which we start labeling it as tricuspid regurgitation. We also modify is that trivial, mild, or holosystolic, and the minimum of 3 readings is compulsory before you label it as tricuspid regurgitation. Now, when we combine the serum markers and the ultrasound markers, we come to our age-old friend, which is our combined first trimester screening. Very simple. Age-old, tested. Take the mama's blood for HCG and PAPE, combine it with the nuchal translucency on the ultrasound with the background of mother's age, height, and weight, we give a result. Triple test. Triple test involves 3 factors: HCG, alpha-fetoprotein, and unconjugated estradiol. But I would really grab this opportunity to inform the learned forum that triple test is now obsolete. It has a very high false positive rate and a very low detection rate. So please do not advise a triple test to your patient and have a pseudo feeling of assurance for yourself and your patient. Quadruple test is done in the second trimester. Just for naming, it involves HCG, alpha-fetoprotein, unconjugated estradiol, and inhibin A. New tests are coming into market called as the quad test, wherein along with HCG and PAPE, we are involving alpha-fetoprotein and PIGF. What happens? It increases our detection rate and drops down our false positive rate. These are some screening results wherein we try to find out which problem is there. In trisomy 21, we would see that there are low PAPE values and high HCG mom values. When it comes to trisomy 18, we have very low PAPE and very low HCG moms. The same follows with trisomy 13. In triploidy, we have a different picture altogether. This is a very famous paper wherein the sensitivity, the detection rate, and the false positive rate has been determined. So we see that when we combine the combined nasal test, the combined blood test with the nasal bone or tricuspid regurgitation or the ductus venosus flow, we get a detection rate of around 93 to 96%, and the false positive rate drops down to 2.5%. NIPT, our new friend. Everyone thinks it's a savior of all. What exactly is NIPT? Nothing. Mama's blood is taken and we try to look for cell-free fetal DNA from the mama's blood. But what exactly it helps us to do? Does NIPT helps us differentiate between the free fetal DNA in the mama's blood, which are of maternal origin and fetal origin? Yes, these days, SNP-based NIPTs, or I'll call it a non-invasive prenatal screening test, does help you to differentiate between serum, between the maternal origin and the fetal origin cell-free fetal DNA. It's supposed to have a very high sensitivity and a very low negative predictive value. Coming to the screening in twin pregnancy, in twins, combined screening test really stands a value, but with a detection rate of only 75% and a false positive rate of high as 9%. We don't advocate quadruple screening test in twin pregnancies. NIPT can be used in twin gestations. It is of more use because in monochorionic twin gestation, there is only one chromosomal matter which we are trying to test because the baby splits into two. And in dichorionic twin gestations, we can use SNP-based NIPTs, which can help us to give individual fetal fractions. What are the disadvantages of NIPT? The cost is high. The results are less accurate for trisomy 18 and 13. Other aneuploidies can be missed, and it doesn't help us to screen for preeclampsia, FGR, and other anomalies. Best test. How do we label it as best test? We look for detection rate, false positive rate, positive predictive value, and negative predictive value. Just brushing up the basics a little. What is detection rate? The number of the abnormal babies the test can pick up is called as the detection rate. What is a false positive rate? Once you say that the baby has the probability of having an abnormality, but the baby on invasive testing turns out to be normal on an invasive testing, determines the false positive rate. Positive predictive value, the chance of a positive screening test turning out to be actually positive, that is the true positives. And what is a negative predictive value? That is the chance of a negative screening test actually giving you a normal baby, that is the true negatives. So we should always target at the tests which have a high detection rate, low false positive rate, high positive predictive value, and a very, very high negative predictive value. The FMF suggests that for the screening criteria, high risk for them is 1 in 10. They divide from 1 in 11 to 1 in 1,000 as an intermediate group, and low risk where the risk is less than 1 in 1,000. The intermediate group, the Fetal Medicine Foundation advocates that we subject them to the cell-free fetal DNA testing. Those test out to be positive can go ahead with invasive testings, and those test out to be negative can go ahead with the normal routine screening. So what do we try to do? We try to get best of both the worlds. As far as possible, advocate a combined screening test. If in case you have a patient in the intermediate zone, try and advocate NIPT to such patients, because contingent form of screening helps you to narrow down your window of positivity to a very great extent. The current criteria in India which we use the cutoff of 1 in 250. We advocate NIPT for the intermediate risk between 1 in 250 to 1 in 1,000. And greater than 1 in 1,000, we classify them as low risk. So what is the verdict? No prenatal testing, screening and diagnostic, or directly diagnostic? It is a thought for the day. I guess we are in a world where we all are very much aware of our health. So everywhere you go and see this health checkup, that health checkup, master health checkup, woman health checkup. So let us advocate this concept as a fetal health checkup, wherein we would include maternal age, nuchal translucency, nasal bone, tricuspid regurgitation, ductus venosus, maternal serum screening, and mean arterial pressures into the package. Thank you so much.
Thank you, Usma. I think that was a wonderful talk. I think Dr. Kundari asked you about enhanced quadruple testing.
Yes, ma'am. Ma'am, enhanced quadruple testing is wherein along with beta HCG and PAPA, you try to involve alpha fetoprotein and PLGF. It gives us a better detection rate and reduces down our false positive rate. It takes us to a detection rate of almost alpha fetoprotein in the first trimester is not used for open neural tube defect screening. It is used for improving your chromosomal aneuploidy screening, and it drops down your detection rate, ma'am, to 2.3 to 2.5%, ma'am.
I think, but very few labs are doing the enhanced quadruple, right?
Yes, ma'am. Very few, ma'am. Perkin Emler, ma'am, usually does that, ma'am.
Right. Yeah. Any questions? Dr. Revati, madam, Amala, ma'am. Are they here? Dr. Revati, ma'am? Okay, they're not there. So,
Hello.
any
It was a nice talk. She had
Yes,
explained it in a very detailed manner. Even though it is, we are not able to do this second trimester scan and all, we are able to manage. But the anomalies only, it will be difficult. You know, again, up to 20 weeks, I will always refer to the sonologist to get the things.
Okay.
Are we going to the next topic?
Yes, ma'am.
For preeclampsia.
So we are moving to the next topic. Screening for preeclampsia. Ma'am, shall
she is the consultant fetal. Dr. Ponmali Ganesan. She is a consultant fetal medicine, the fetal clinic Pondicherry. Undergraduate from Thoothukudi Government Medical College, postgraduate from JIPMER, postdoctoral fellowship in fetal medicine from Mediscan, Chennai. So award AV. What is this award?
Machigui Memorial Gold Medal.
Machigui Memorial Gold Medal Award for best outgoing student in MS Obstetrics and Gynecology 2015. Presentations presented. Oral paper on fetal intrauterine blood transfusion, a case series managed by high volume intrauterine transfusion at the Asia Pacific Conference on Fetal Therapy 2017. Presented oral paper on prenatal cardiac presentation of heterotaxy, a 10-year review of a single center experience at fetal echo and perinatal cardiac morphology symposium. Then invited lecture on prediction and prevention of preeclampsia at second fetal medicine for the practicing obstetricians. Presented an oral paper on prenatal diagnosis and heterotaxy syndrome and autopsy correlation. A 12-year review of a single center experience at the prestigious 17th World Congress in Fetal Medicine at Athens in 2018. Publications at national and international journals. I invite Dr. Ponmali to give her lecture.
Thank you, ma'am. Thank you for the introduction. Good evening, everybody. At the outset, I would like to thank Maldi ma'am and TNFOG Society for giving me this opportunity. Am I audible?
Yes.
Okay.
Yes, Ponmali.
Hi, ma'am.
Hi. Above all, Dr. Ponmali is a very, very sincere, dedicated fetal medicine specialist and extremely works to the core towards the well-being of the patient. So that is what I know for Ponmari. I call her Pons.
Thank you, ma'am.
Thank you, Ponmari, for accepting this
Thank you,
invitation.
ma'am.
Thank you.
And the previous two talks were excellent. I must appreciate. So can I start now? Can I share my screen?
Yes,
Yeah.
yes, please.
Share your screen.
My screen visible, ma'am?
Yes, yes,
So can I start?
yes.
Yeah.
Okay. I am going to talk about screening for preeclampsia. One of the goal of first trimester scan, apart from detecting early fetal anomalies and Down syndrome screening, is screening for preeclampsia, because we all know that preeclampsia is still the leading cause of perinatal morbidity and mortality. If you take the annual numbers of maternal mortality rate, this chart I have shown for the state Kerala, it is almost constant. It is not in decreasing trend. That means the perinatal mortality we have not yet managed, and we know that preeclampsia is still one of the major cause. And we all know preeclampsia is a multifactorial disease. There is multiple complex interaction at genetic and immunological level, and there is release of vasoactive mediators, and there is a tilt in the balance between vasodilatation and vasoconstriction towards vasoconstriction, which leads to preeclampsia. Now, though the disease of preeclampsia, the clinical disease as such, it manifests in third trimester, but the pathogenesis, it starts well in the first trimester, that is early in first trimester. The mothers who are having some baseline risk factors, additionally, there is defective trophoblastic invasion, which leads to placental ischemia and oxidative stress, which causes release of various vasoactive inflammatory mediators that causes endothelial dysfunction, which in turn further worsens the placental ischemia and oxidative stress, and ultimately the disease manifests in late second trimester or third trimester. Now, if we go only by the history, the traditional risk factors according to NICE and ACOG guidelines, either we will be under-detecting the preeclampsia or we will be over-treating the preeclampsia, because the detection rate is very low based on the NICE guidelines, and according to ACOG, though we will be able to pick up the higher cases, but the false positive rate is close to 50%. Now we know there is some baseline risk factors. On top of it, there is a defective trophoblastic invasion, placental ischemia, and there are various vasoactive inflammatory mediators involved in the pathogenesis of preeclampsia. If we have some measures to detect defective trophoblastic invasion, placental ischemia, and the inflammatory markers, we will be doing a better performing screening test for preeclampsia. So, our screening strategy for preeclampsia is a multi-marker screening according to FMF guidelines, where the first step is taking a detailed history, because the history has a major weightage in risk calculation. And we all know that these factors, the advanced maternal age, IVF, chronic hypertension, diabetes, SLE, all these have a high risk factors for preeclampsia. Step 2, you have to take a mean arterial pressure. It has to be done properly according to the protocol. The patient has to be in a sitting position with their legs uncrossed and arms to be supported at the level of heart. And we should use an appropriate cuff size. After a resting period of 5 minutes, we should take 2 recordings simultaneously. And finally, we have to take a mean arterial pressure. And we all know that in patients who would develop preeclampsia in later gestation have some form of endothelial dysfunction, and their mean arterial pressure is slightly on the higher level compared to a normal woman. So, the third point in screening for preeclampsia is taking mean uterine artery PA. For those fetal medicine or other radiologists who are already doing fetal scans, it is very easy to take the uterine artery PA. If we are doing transabdominally, we keep the probe across the sagittal orientation of the uterus and cervix, and we tilt the probe towards right and left paracervical region, and we take the uterine artery PA at the level of internal os. What we take in the uterine artery, it is we don't take the right and left separately. We take the mean uterine artery PA, and notch we are not taking separately. So we have to calculate the mean uterine artery PA. And why it is important? If there is a defective trophoblastic invasion, and the mean uterine artery PA will be elevated. And the fourth step in preeclampsia prevention is measuring the placental ischemia factor. And among the various factors, the PAPE, PLGF, and SFLT1, PLGF has been shown a better screening tool when compared to PAPE and SFLT1. PLGF, which is an pro-angiogenic factor. Along with VEGF, PLGF promotes a vasodilatory environment. In preeclampsia, this SFLT1, which is an anti-angiogenic factor, it binds with VEGF, that is vascular endothelial growth factor, and thereby inhibiting its vasodilatory effect. But in the presence of PLGF, it binds to this SFLT1 and thereby promoting the effects of VEGF. So VEGF, PLGF promotes the vasodilatory environment, whereas SFLT1, it promotes the vasoconstrictory environment. So if we are able to measure in preeclampsia, the PLGF, PAPE levels will be low. So we can measure PLGF and get the multiples of median for preeclampsia risk calculation. So after taking the maternal sample for risk calculation, that has to be processed immediately and in acceptable platforms. The Roche and PerkinElmer-Delphia platforms are standard platforms we use. Once we get the risk factors, we measure the mean arterial pressure, mean uterine artery PA, and PLGF MOM. Like similar to NT risk calculation, Down syndrome risk calculation, the risk of PE is calculated. All these mean arterial pressure, uterine artery PA, and PLGF MOM are multiplied with the a priori risk, and we get the final risk for preeclampsia. So this is the multi-marker screening for preeclampsia. There are online calculators, even SMS calculators are available to calculate the risk. And we use the cutoff of 1 in 100 for high risk for preeclampsia. Now, so once we do the preeclampsia screening, what is the performance of PE screening? So if we use the multi-marker screening, that is based on history, mean arterial pressure, uterine artery PA, and PLGF, we will be able to detect 90% of early preeclampsia, that is preeclampsia before 34 weeks, and around 75% of preeclampsia that develops before 37 weeks. If we go only by the traditional risk factors, according to NICE guidelines, we will be able to detect only 40% of preeclampsia and around 90%, but at a false positive rate of 50% according to ACOG guidelines. So this multi-marker screening model for preeclampsia has been very well validated across various countries, including one study from India by Suresh sir. Now, once we screen and detect those women who are at high risk for preeclampsia, do we have effective preventive measures? Yes, we have. Though in the past, there were conflicting evidences because of lack of complete understanding of pathophysiology and inappropriate timing and inappropriate dosing of intervention. And now we have current evidence for standard prevention of preeclampsia. Initially, the calcium supplementation was studied in various studies. It has shown benefit in women who are already taking low calcium diet. If we give them adequate doses of calcium, it has been shown that it is reducing the risk of preeclampsia. And then the effects of aspirin, it was observed in 1979 by Crandon et al., where those pregnant women who were taking aspirin for some other indication, it was shown beneficial for preeclampsia reduction. Later, after few decades, a study by Robage et al., who conducted studies in 12,000 patients, where it has been shown that aspirin given appropriately, that is before 16 weeks, rather than after 16 weeks, it has been shown beneficial when compared to placebo. And if with the dose of 150 mg, the risk reduction was most beneficial when compared to other doses of 50, 60, and 75 mg. This was the study done by Nicolai's group, Aspri trial, everyone must be knowing, which was released in 2017. In their study, they have shown they have randomized around 1,776 women. After screened positive for preeclampsia, they randomized the group into one those receiving aspirin, the other one who received placebo. And it has been shown that The group which received aspirin, who screened positive for preeclampsia, then aspirin was started at less than 16 weeks and continued till 36 weeks. It has been shown that the risk reduction of early preeclampsia, that is before 32 weeks, was near 90%, and less than 34 weeks preeclampsia prevention was nearly 82%, and less than 37 weeks it was around 60%, and the rate of NICU stay was reduced to 70%. So we found the magic drug of aspirin, but can we prescribe to everybody? No, it is not without its own complication and side effect. If we start giving aspirin to everybody, and especially if we start giving aspirin for those more than 16 weeks, it has been shown that aspirin can slightly increase the risk of placental abruption than those who were given less than 16 weeks and for a high risk group. So aspirin has its own side effects. Gastrointestinal bleed or cerebral bleed can happen, but this can be reduced severely by selective prescription of aspirin for only screen positive women. And if the pregnant woman has some minor vaginal bleeding, aspirin need not be stopped. So what will happen if we start giving aspirin universally? So we can notice less adherence because they will consider it as like any other hematinics like iron calcium. They may not take it properly, and more women would be subjected to this aspirin side effects, and abruption risk is slightly increased if we start giving to everybody. So what is the clinical implication? The number needed to screen to prevent one preterm preeclampsia is only 400. But if we take Down syndrome, we have to screen 1,100 women to detect one Down syndrome. So we have to start applying multi-marker screening tool for prevention of for detection of preeclampsia. So is it feasible across all places? It has its own disadvantages because for risk calculation, we need the algorithms and we need the internet availability, and we need expertise, special training, especially to take the chain artery PA, and we need a special platform, accredited platform to take the PLGF and MOM. So it is not without its disadvantages, but whenever feasible, we should try to practice the multi-marker screening algorithm model. So what is the role of heparin for preeclampsia prevention? As of now, it has not been shown highly beneficial for preeclampsia prevention. And we conducted one RCT when I was a PG in JIPMER. The role of nitric oxide was studied in 100 women. We randomized into two groups. One group received aspirin, the other group received isosorbate mononitrate, and we did not find any significant increased benefit of nitric oxide over aspirin. So as of to summarize, if we do a multi-marker screening, preeclampsia multi-marker screening, we can categorize the group into two groups, low risk and high risk. For the low risk group, the routine antenatal care is given, and the high risk group, we have to start aspirin before 16 weeks, 150 milligram at bedtime, and it has to be continued till 36 weeks. And the optimum dose of calcium has to be advised. And for the screen positive women, we have to advise appropriate growth surveillance starting from 28 weeks. And role of aspirin is still under trial, so we need not prescribe heparin for prevention of preeclampsia in screen positive women. Thank you.
Correct, evening 5 o'clock. Thank you. Thank you, Bons.
Thank you, ma'am.
That's fantastic. So as per, I found a recent Royal College guideline which came out that start aspirin after doing your first trimester screening and stop aspirin by 34 weeks. What is your take on that? So when I actually posted that guideline in my group, there are a lot of controversies saying that no, we want to continue till 36 and 37 weeks.
Even in our study, ma'am, we found effective when it was continued till 36 weeks.
So 36 we can stop.
Yes, ma'am.
Okay.
And it's 150, is it?
150 milligrams.
150. I think Dr. Sinishan is the expert in Preeclampsia screening, right?
Yes, sir. Yes, sir. Your expert opinion, please.
Yeah. Any expert opinion which you want to like to add?
I think Ponmori has used her phones and explained everything very well. So she was basically talking the best evidence available. The best evidence is not aspirate trial, the meta-analysis done after the aspirate trial by Roboj et al.
Yes.
So which had shown the maximum benefit of aspirin if used before 16 weeks at a dosage of more than 100 milligram. So that is the best evidence that we have right now. So compared to that, it's individual take on, when to stop and all that. But since aspirate trial has shown 36 weeks as one of the endpoints, and we know that neonatal complications and term preeclampsia are more after 36 weeks. I mean, the prevention of aspirin for them is less. So 36 weeks seems to be a good choice to stop aspirin therapy.
So this is based on the body weight, you can change the dose of aspirin. So any take on that?
Yeah.
For example, she's a very thin woman with a BMI of say 18 or 17.
That is what I was also thinking. 75 we are giving routinely, but if she's obese, we have to switch over to 150. Is it that or any other criteria for a higher dose?
Yeah, correct, ma'am. Low BMI, we can give 75 mg.
I want to add one point here by FIGO. FIGO has published a guideline in 2019, which says that women weighing less than 45 kg can be offered 100 milligram, not 75 milligram. Women who are weighing above 45 kg, they can be offered 150 milligrams. So this is FIGO guidelines, which we can all follow.
Do we have 100 milligrams?
Commercially less available because market is bombarded by 75 milligram. But yes, 50 milligram, 2 tablets can be had, and at bedtime. Isn't it, Ponmori?
Yes, sir.
Yes.
And
see, in IVF pregnancies.
Yes, Kandavi.
I mean, IVF pregnancies, we give them low dose aspirin and then they continue. But in spite of it, we have seen patients developing PH. And so what's the take on that? Because they have been given following the luteal transfers.
Yes, ma'am. IVF pregnancies, it is better we perform the screening protocol. If they turn to be high risk, better to change to 150 mg. If we are already giving a low dose, we can increase the dose to 150 mg.
And according to ASPER trial, I think 100% it does not prevent.
Yeah, even early preeclampsia, it is 92%.
Yeah, 92%.
And
risk of bleeding?
Gestosis scoring, or from the clinical scoring itself, we start them on aspirin and calcium, and of course, routine follow-up.
Risk of bleeding?
Bleeding with
Even
risk of bleeding?
no contraindication.
The dose of 150.
If there is a bleeding, maybe temporarily we can stop, but definitely we can restart after a couple of days.
Okay. Thank you.
Thank you, Dr. Panna. The chairpersons can wind up.
Okay. All the 3 speakers have done a job, good job, and a clear idea about this aspirin, preeclampsia prevention, and also this screening, aneuploidy screening, and of course, Vaige Express Moletis talk, all those things. Okay. Really, all these things have given a take-home point. I'm sure we shall be definitely of use for the day-to-day practice. I think maximum attendees are there, I believe. General obstetricians who are using scan on their own. Okay, they must know all these things. Because suppose something abnormal find or you anticipate something, you should know when and how to refer earlier so that the best can be done to the patient. That is very, very important. Amala?
Yes, that's the same opinion as like Revati, because first this NT scan and the anomaly scan usually better to get an second opinion from the sonologist to save our skin also, that helps. And the last talk, it is an eye opener for us, because if high risk cases and if you suspect preeclampsia, then aspirin recently only they have changed the dose to 150 milligram, I think. And then we were giving up to 32 to 34 weeks only. Till now we are doing it, but we may continue it. That is a new thing for me, to continue up to 36 weeks.
Yes.
The 75, there is no dose like 75 milligram nowadays. What we give, you give the full dose of 150 milligram per day. So.
Okay, ma'am.
Okay, we can move on to the
Thank you, ma'am.
panel.
Thank you.
Over to Dr. Radhika.
Yes, ma'am. So the next session is the panel discussion, interesting case scenarios in early pregnancy. So the
Not
expert,
early pregnancy. First one.
ma'am, the expert panelists, I invite Dr. Kundavi Shankar ma'am and Dr. Sinish Kumar. Dr. Sinish Kumar will be the moderator. He is a graduate from GMC Alapula, Kerala, and MD OG from GMC Baroda, Gujarat, and he's done his specialist training, fetal medicine from CMAR Edapal, masters in maternal fetal medicine from Fetal Medicine Center, Barcelona, MSc in clinical genetics, Chinese University of Hong Kong, PG degree in fetal cardiology, University of Barcelona, and Trilec fellowship in maternal fetal medicine, Perugia, Italy, and training in fetal therapy, Siriraj Hospital, Bangkok. Training in fetal cardiology, Royal Brompton Hospital, London, and he has got 26 publications in national and international peer journals. Special interests are fetal genetics, fetal therapy, fetal cardiology, fetal medicine training. So he's got a wonderful CV. And next, I invite Dr. Kundavi Shankar ma'am. She's the HOD and senior consultant. And she's done her diploma in reproductive medicine, diploma in advanced laparoscopic surgery. She's a famous national board certified obstetrician gynecologist, specialist in reproductive medicine and laparoscopic surgery for more than 20 years. We all know her. Now she's also a committee member, fertility preservation committee member, endometriosis committee member, has fellowship program and IRM, MM, invited faculty at conferences, and she's got numerous publications to her credit, and she's the chairperson for anti-sexual harassment committee, MMM. Over to you, ma'am. Panelists are Dr. Revathi Chandrasekharan, who is a consultant Fetal Medicine Center, director and lead consultant, Sprout Fetal Medicine Center. And she has numerous publications and paper on mental health of antenatal women during COVID, and fellowship in fetal medicine, ICOG certified gold medalist. The other, and Dr. Reshma Marineni, is a fetal medicine consultant, fellowship in fetal medicine, and she is a consultant training fetal medicine, UK certified fetal medicine foundation, fellowship in fetal medicine, 2 years at Bangalore Fetal Medicine Center, and diploma OBG, JSS Medical College and Mysore, Karnataka, MBBS from Bangalore, Karnataka. She has numerous paper and poster presentations. The next consultant, Dr. Sonam Modi. She's a consultant fetal medicine. She has done her DIP&B from JLN Main Hospital and Research Center, Bhilai in 2016. Worked as senior resident at GMC Akola from 2016 to 18, and she's ICOG certified fellowship in fetal medicine. And so over to the panelists, and let's start the program. Discussion.
So are my slides visible?
Yes, yes, it's visible.
So thank you, team TNFOG, and special thanks to Malati madam for the kind invitation, for a session on first trimester screening, which is so relevant these days. And all the talks that were completed were so wonderful. So for some time, I think I have to take the Vande Bharat from Tamil Nadu to Kerala, from where I'll be, conducting this panel session, which is based on real life scenarios. These are all real cases which have come in the department, which has actually come in my department. And for the audience, let me know it's not like any other panels, because in almost this is a well-known secret, because in all panels the questions are shared to the panelists, but here all the panelists, Kundavi madam, Reshma, Sonam, and Revati will be talking from their real life experience. But the first and the foremost thing that we should know in screening. Now we saw the healthy discussion that was held in first trimester screening, and following that preeclampsia, and talks by Uzma is there is no single best approach when it comes to screening. So when there is a scenario, there is something that which Malti madam may advise. There is an maybe a management which Kundavi madam may advise, and then there are all different opinions from different fetal medicine specialists. So there is no single best approach. Rather, we have a cafeteria approach which we will be seeing today. So today the theme is to seek directions in screening from opinions from all the non-specialists. And thanks to Malti madam for the wonderful lecture on scanning at 11 to 13 plus 6 weeks. Uzma on the talk on Down syndrome, and Ponmori for her talk on preeclampsia. None of these are covered today. The basics are not covered today because we are all going into real life scenarios. All the panelists have been introduced. So we go to the first case, which is understanding the basics of screening. So about a year back, this 38-year-old second gravida came to our department. She had a previous normal delivery. The child was healthy of 5 years. And she was referred to one of the most common reasons for referrals these days. The final risk of the combined test is low, but the biochemical component is suggesting high risk. So, so Sonam, can you interpret this test for us, which shows? Can you give your valuable opinion? What do you feel on this?
Sir, this report shows sir, positive risk for Down syndrome is low risk, but biochemical result is found to be increased risk. Sir, we have to see for the report whether it is valid. Like we have to see whether date of birth is there, weight of the patient.
Anyway, I'll be coming to it. So in this test, what you find is that the final risk is low. But
yes, sir.
They have shown this confusing graphs, which are so confusing for the obstetricians in their busy practice. Red color. So all the attention goes there, and it shows that the biochemical risk is high. So Kundavi madam, do you encounter such reports in your practice at Triple M?
Yeah, definitely. Then we always ask, we just call up and find out whether the proper information is given to the lab. And also I look at the pictures, what is given by my sonologist, whether it's been taken properly. And then we go ahead with that.
All right. So Reshma, can you tell me how to judge the reliability of a screening report? Because there are n number of labs which are doing screening. And because it pertains to the prenatal scenario where a good quality result is very, very important. So how do you judge whether a screening report is of good quality or not? Does it matter? So the question is to Reshma. So I think Reshma is not coming. So can I ask Revati to, give, yeah.
Hello.
Yes, is it Reshma
Yes,
there? Yeah. So when you get a screening, you're audible. When you get a screening report in your hand, how do you judge whether this report is reliable for the particular scenario? Are all reports equal?
No, sir. We hello.
Yes, you're audible.
We can hear you.
Yes, we first we have to see from which lab have they done. Basically, FMF will accept only three these things: Delphia, Roche, Crypta, and which is time resolved fluoroimmunoassay and electrochemical nuisance. So, and one more thing is we also have to see if the cold chain storage has been maintained. The date of collection of the sample and the date of report to be ideally not more than 7 days maximum. So we look into all these, and once the biochemical risk has come, once we take the report of the biochemical risk, we re-enter the MOM values into the FMF software, which is definitely accepted. That is only Delphia, Roche, Bramskipta, and we recalculate the risk now based on maternal age, NT, and the serum biochemistry. And that recalculated risk, based on that, we will take the next decision what to be done.
So Revati, Dr. Revati, is it important that the scan is done as per the guidelines? Is there the quality of images, especially nuchal translucency, important for a good quality report? So Revati, are you there?
Yes, sir.
Are you there? I think
You
loss
can
of
unmute
signal.
yourself.
Hello,
Uh,
I'm very
hello.
sorry, sir. It's breaking for me. I don't know what's the
All right.
problem here.
Okay.
Sir, kindly can you please repeat the question? I'm very sorry.
So yeah. So I was asking. Reshma was telling about the importance of good the lab quality. Is it also important that the images should adhere to particular quality and standards? Does it matter in the final result of your first trimester screening report?
Yes, sir, it does matter because the combined test, as the name suggests, we have three things combined and put together to arrive at a diagnosis. I mean, to arrive at a value which is going to determine whether the baby is supposed to have a chromosomal aneuploidy or not. So all these three things has to be taken in a proper manner. For example, the ultrasound, whatever measurements that we are taking has to be properly taken, and the biochemical values, which the sample we are collecting, the sample which is being transported, and how the sample is being processed, those things are very important. So quality check is very much important in all three categories. Taking the history, entering the history, sending the history, taking the images, giving the measurements, and processing the blood parameters.
So excellent. So n number of labs are performing screening these days, and it's very important that the lab maintains a certain quality, and it is equally important that the sonologist who is performing adheres to the guidelines from Fetal Medicine Foundation, which says the most important things. The scan should be done between 11 to 13 plus 6 weeks of gestation. The CRL range should be 45 to 84. And there are very important criteria on how each image should be procured. For example, how the nuchal translucency image should appear, how the ductus venosus should be appear, how the tricuspid regurgitation should appear. So Uzma has highlighted all this in her presentation. So it is very, very important that all these images adhere to those clinical guidelines. So Kundavi madam, sitting as the HOD of such a prestigious institution, many laboratories would be coming to you regarding, they might be offering that they are doing the best test ever in the market. Our NIPT is the best, our double marker is the best. So how do you judge that that laboratory is adhering to a particular guideline? Or can you share like which lab you're working with and how has your experience been with those labs?
As of now, we are working with Medgeno. We always look at how they report and look at those reports, and then we go about with it.
All right. So whenever a laboratory comes to you, the two important things that you should ask them straight away, because many obstetricians, they are very, very busy in their practice. First of all, ask them which platform they are working on. So the Fetal Medicine Foundation UK has approved only 3 platforms for performing the first trimester screening. These are the Delphia, the Roche, and the Cryptor, right? And one more question that you can ask, which 99% of the laboratories might not be telling you, is, are they performing an audit of their biochemical results? So almost all the standard laboratories such as Medgenome or Perkin-Elmer, they do an audit of their biochemical results every 6 months or 1 year, with which they change their MOM values, and they are able to improve the quality of their reports. So madam, do you have an experience of working on dried blood spot assay, or you go for a serum-based screening for your patients at MMM?
Serum-based.
Serum screening. So Reshma, does it matter that the patient offers a serum screening or a dried blood spot assay?
Mostly the serum screening that has been reported in the Indian scenarios.
So as Uzma was pointing out in our presentation that, the transportation, the cold chain transportation can affect the biochemical parameters, especially beta HCG. And for this reason, if dry blood spot assay is more thermostable and can offer better results, but it is marginally more expensive than the serum screening by a factor of about 100 to 300 rupees. So all the labs give you a test request form which should be properly filled to get the best results for that particular test. So Sonam, what are the common errors these days that you encounter in first trimester screening?
So we have to see for the HCG injection, like when is the HCG injection has been given, because if it's
this is
given
particularly important. Yeah, this is particularly important if it is an IVF center, right?
Yes, sir.
Yes.
So we have to look for the maternal conditions, whether there is any history of bleeding, PV, diabetes. We have to also ask whether there is any history of spontaneous conception or IVF conception. If it is IVF, then we have to look for the age of the donor. We have to look for the date of the birth. We have to confirm whether it is singleton pregnancy or twin pregnancy. And then in cases of twin pregnancy, chorionicity is to be seen. And
Right.
so accurate measurement and documentation of CRL is a must.
Is a very must thing, because all interpretations are done based on CRL rather than the gestational age. Remember the range of CRL which FMF UK says 45 to 84. So I think most of the fetal medicine specialists like Ponmori and Uzma, and they would agree that these days the most common mistakes in first trimester screening report is the date of birth of the woman is not mentioned, because again the interpretation requires the calculation of the risk requires the risk of the woman having Down syndrome at term. So for that, the date of birth is very important, and not just a random age like 32 years or 33 years, but date of birth is equally very important. And in the previous discussion, it was also told how donor oversight program, it is important to put the age of the biological mother into this. Another very common mistake done is the absence of nasal bone. So if the nasal bone is absent, if the sonologist is writing that the nasal bone is absent, the TRF form, in the TRF form, it should be written that the nasal bone is absent. Often we find that the risk is calculated based on the presence of the nasal bone, even though it is absent, right? So Revati, if it is a surrogate mother, like again in assisted centers, ART centers, it's very important. In a surrogate mother, which age should be taken into consideration, the biological mother or the mothers who has donated the oocyte?
I think the surrogacy of late, the donor oocytes has been banned. Probably an egg donation program. Probably donor age should be mentioned, not the recipient's age.
Yeah, actually, I want to reframe the question. If it is a surrogacy, is it the mother who is carrying the fetus? Her age should be mentioned, or the mother, the biological mother's age? That was my question. Sorry for using the term donor oocyte.
I think the one who's
no doubt
given,
there. No doubt there.
No doubt.
The biological mother's age, right? Because this is also a confusing scenario, and there have been multiple calls regarding which age should be mentioned. So coming back to our case,
we found that question, Dr. Sonich. A small question. Suppose you have a donor, you've used a donor oocyte in the surrogate mother. Then what age will be mentioned, and how will you?
So that's what Kundavi madam was saying.
ART bill says no donor eggs for the surrogate mother. So I think the last 2 years we have stopped using the donor eggs for surrogate mother. Yeah.
All right. So coming back to our scenario, we found that the final risk was low, but the biochemical risk was high. The scan was done as per FMF UK guidelines. The images were of good quality. The woman was referred actually for an invasive test. So I would like to ask Sonam, in this case, the images of good quality, the final risk is low, but the biochemical risk is high. So what would you choose in this scenario? A repeat combined test, or a second trimester screening test, or an NIPT, or an invasive test?
So we have to see for the new markers like nasal bone, tricuspid regurgitation, like tricuspid Dopplers, DV Dopplers. All this thing is to be considered. If everything comes out to be low risk, so everything comes out like it's still biochemical risk is high risk, then we have to go for NIPT. So because NIPT will be having sensitivity of 99.9% for T21. And it is
Malti madam, what would you do in this scenario? Like the biochemical risk is high, the final risk is low.
High. If the biochemical risk is high, I think we would do a complete, suppose NT is not done with us, we have to do an NT, the nasal bone, ductus venosus tricuspid regurg, and then load the biochemical markers which have been come into our FMF software and arrive at a particular risk. Suppose the risk is, say, less than 1:1,000, more than 1:1,000. I think nothing needs to be done. That's what we do.
All right. In this, the risk was more than, the risk was about 2,200.
No, if it is intermediate, then we do an NIPT. But overall risk is 1:2,000. I think it's low risk. Can I go with?
All right. So, Kundavi madam, you have
to. Can I have a question if I'm allowed? Please. Suppose if you have this report and it is incomplete, can we send back the reports to the sonologist to say that she has to do the tricuspid and the ductus to give us the entire
It's not
panel.
possible. It's a very good practical scenario that you have put. Maybe you can ask the lab to recalculate based on some errors that were in the scan report, but it's difficult for the sonologist to again take PR, because mostly the gestation age would have crossed 13 plus 6 weeks, and then by scan parameters taken on different days, it is difficult to recalculate. But one important message I want to drive here is, in this scenario, everything is correct. You can go for a repeat combined test if she's within 13 plus 6 weeks. Maybe she can go for the second trimester screening test, not such an optimal approach. But as Sona was saying, we can go for an NIPT, and even an invasive test. If the couple are very anxious, they can go for the same. In this case, the couple opted for combined test again, because thankfully she was within 13 plus 6 weeks. She came as low risk for Down syndrome, and then she was scheduled for a morphology scan at 21 weeks of gestation, which, however, showed this finding. So, Revati, can you highlight, is there some abnormality in the heart here? So I think you can see parallel outflows.
Like a
here,
parallel
right, Malati,
outflow.
Parallel outflows. So this is a deep transposition of great arteries that was diagnosed at the anomaly scan. And now the couple are very angry. They're telling, we did a combined test in the first trimester. You said everything is normal, and now there is a major cardiac anomaly. A very practical scenario these days if the counseling has not been done properly. Yeah. So, Malati madam, I think you might have, in your big practice, you have encountered such situation very often.
Yes.
How do you counsel the couple?
Combined test is normal, and now you've told me that it's a cardiac anomaly. It's always,
yes, I think this message is for the obstetricians. This message is for the obstetricians, because they get a scan report saying there is an anomaly. The combined test risk is low, and the first thing that the couple will ask them is, you said everything is normal during the NT scan, the FTS report. So how do you counsel, ma'am, in these scenarios?
I think the detection rate of every test has to be explained to the patient in detail. For example, the combined test and the NIPT, all this should be explained to the patient in detail, and tell her that only 90 to 90% detection rate is possible. We are not beyond that. So we cannot detect 100% of the aneuploidies in your combined test. 8% is likely to be missed. So I think that mental preparation of the patient is very important, so that we're not alarmed when you find something abnormal in an anomaly scan. So detection of every test should be informed to the patient.
Kudri ma'am, have you encountered these situations, and how do you counsel the couple in this case?
Yeah, because we do very often, because we do have a cardiac center in our unit. And probably, patients do get angry. And then I think it's a part of us to tell them, like every trimester, that we can identify the anomalies, and not all anomalies can be picked up in the first trimester. So I think the counseling plays a major role. Correct. And we do involve the pediatric cardiac surgeon as well for another opinion for these patients.
Right. So anyway, in this case, I think not just in this case, in majority of obstetric units, the patients think that the first trimester screening is for almost all abnormalities that can happen during pregnancy. But it's important that there is a proper pre-test counseling, and that information leaflet is provided to the couple that prenatal screening is actually for Down syndrome and not for all other abnormalities that can happen to the fetus or the neonate, including structural anomalies, autism, etc. Because in popular literature, conditions such as autism are more popular than Down syndrome. And the expectant couple think that through a FTS, everything can be diagnosed. So it is often a nightmare for the obstetricians to explain this. Anyway, in this case, everything was properly explained. They were referred to pediatric cardiologist, and a term delivery was done in a pediatric cardiology and surgical center. Arterial switch operation was done, and now the baby is doing well. So the pertinent question here is, we have a different options available these days. We have NIPT, we have invasive test. So, Kundri madam, what is your screening test of choice in MMM?
I think we go with a combined test. And if they're about more than 39 years or something, then probably I would combine with the double markers with NIPT. Yes, because especially with their IVF patients.
Yes.
Because they're more anxious about when you talk to them about the other invasive, like amniocentesis.
Correct. Malti madam, what's your approach? Like, after what age you go for a higher test, such as an NIPT or another test? So, let me pass on this question. Yes, ma'am. So is there an age where beyond maternal age, beyond where you go for higher tests such as NIPT? You also tell them there is something called as amniocentesis also, which can pick up abnormal aneuploidies 100%.
The age is usually the maternal age more than 35 years. NIPT can be recommended. Considering it to be advanced maternal age. And
so the important point that I want to drive to the obstetricians who are attending this session is that in first trimester, we have now various options, not just a double marker, the so-called the combined test with 2 markers. We have the combined test with 3 markers, which includes PLGF for the screening of preeclampsia. We have the first trimester quadruple test, also called as enhanced first trimester screening. Almost all labs are now offering this the first trimester quadruple test. We have the pentamarker test and we have the NIPT also. So for each patient, you can take an individualized approach. The most effective test is definitely the combined test or the double marker test. But depending upon your own discretion, suppose a woman with advanced maternal age, a precious pregnancy because she's an ICSI conception, you can offer advanced options such as NIPT for such women also, depending upon the financial resources at disposal. So all these tests can be offered, and it depends upon what kind of obstetric cohort that you have in your institution, what kind of test then they can offer, they can accept, because it is not just screening. The well done scan with NT and nasal bone, as you can see here, a well done first trimester scan. That's the important point that Malti madam was driving. A well performed first trimester scan with a normal NT and normal nasal bone can pick up 90% cases of Down syndrome, which is almost equal to the pickup rate of combined test with the 2 markers. So I quickly go into the second scenario, which I have named as
one more thing is like when you're counseling for invasive test, I think if the parent says whatever happens, I would accept it, then
yes,
there's no point in giving the amniocentesis to these people.
Probably, yeah. A very important point that I think should be covered in your pre-test counseling, and you can have information leaflets in local languages at your institution, which can improve the understanding and comprehension of these tests from the patient side of you. I quickly go into the second scenario because this is a very, very important scenario, which taught me an important lesson: never take chances. I'll quickly rush through this case. She's a 32-year-old third gravida, 13 weeks and 2 days. She was referred to our center because the first trimester screening test was high risk for trisomy 21. Unfortunately, this woman did not show us this FTS report. That was not purposeful. Maybe she did not show us the screening report. And when we saw the report, which was done from the outside, the NT was 2.6 millimeter, nasal bone was present, and there was nothing abnormal in those report. So this was a FTS report from outside, which was not shown to us that there was screen positive for trisomy 21. And not knowing this screen report, we went with a very high quality, first trimester scan was done from our side, and the NT was in our scan was about 1.7 millimeter. The nasal bone was present. There was absolutely no issues. We went to we gave the biochemical test to a very good lab, and the result came as 1 in 732. So Reshma, what do you think about this scenario? Should we now routinely send this patient back and call her for an anomaly scan?
So 1 in 732 still remains an intermediate risk. So
okay, that's what you want to say. Yeah, you want to go ahead to a higher test. Sonam, what do you think about this scenario?
So this is an intermediate risk, so it's better we go for an IPT, sir. Non-invasive prenatal testing.
Right. Remember, there is no single best approach. Everyone can have an individual choice, right? Revati, what do you think about this scenario? NT is normal, all biochemical markers. Yeah.
The signal has gone. Have you come back?
So definitely, can you hear me, madam? So definitely, this is an intermediate risk. This patient definitely needs a further evaluation. She should be given the cafeteria approach of either an NIPT or an invasive testing based upon whatever they're affordable.
Anyway, what happened is the next day the patient called up and sent the report, this report, and she said there is a screen positive report we had and we forgot to show you. We checked back with our report, which had come a week later, and we found that everything is normal. And we went to the safe approach. We offered an invasive test because we didn't want to take any chances, and this is what came in the, in the diagnostic test. Baby had trisomy 21, baby had Down syndrome. So we, if the patient had not called us back and said that we have a report which says something is abnormal, and you say that the new report is normal, we would have clearly missed this case, because we are clearly going to a scenario whether even if we are practicing in villages where medical legal liability is going to be very high, and therefore we should adhere to standard clinical guidelines always, and always we should give a proper counseling to each report, and we should follow a cafeteria approach. Whenever there is a situation or indication, we should give a higher test in that particular case. So,
is there a
Malti, madam, you want to add?
possibility?
Yes.
Malti, is there a possibility that we had a high risk for trisomy and that the risk is about 700 in the next subsequent scans? Is there a possibility of such?
Yes, it can happen. Yes, it can happen. The major reason for this is as you move from 11 to 13 plus 6 weeks, the NT decreases, whether even if the baby is euploid or aneuploid. Number 2 reason is the biochemical parameters, the discriminatory role that they have in differentiating euploid pregnancies and aneuploid pregnancies, again, is lesser when you go closer to 13 plus 6 weeks.
13.
They perform better when they are near to 11 to 12 weeks. That can explain this scenario. Madam, you want to add something, Malti, madam, here?
I think whenever we have 2 ambiguous reports, one showing screen positive, other one is intermittent, I think we go safe and do an invasive testing, because we don't want to have a downside at the end of the day.
Yes. So
very often we get reports of 1:960 and things like that. So in such patients, we redo the NT based on the FMF guidelines, do a DVTR and arrive at a risk. Suppose the risk is lower, then we just reassure the patient. Sometimes it happens. It is 960, 970 as a closer to the 1000 mark. Such patient, we do the NT based on the FMF.
All right.
And do the risk again.
So panelists like Revati, screen positive results, you would go for a CVS or amniocentesis, because many times obstetricians see a screen positive report at 13 weeks. They're confused whether to go for a Korean villus sampling or an amniocentesis. So what do you think? What is the important difference between the test, and is one better than the other?
So screen positivity definitely implies that the patient should have further evaluation. It can either be an NIPT or an invasive testing. That patient has to take the decision regarding. But I have to explain to the patient that NIPT is still a higher form of screening test, and it has got a sensitivity of 99.9% in detecting the Down syndrome, but it has got a turnaround time of around 2 weeks. There are chances that there may be a failure, culture failure also. We may get a negative report also, in which case we have to repeat the test or go in for an invasive testing. So that has to be explained to the patient. And there is no chances of miscarriage or anything added when we do an NIPT. But when we go for an invasive testing, we get 100% report whether the patient is having a Down syndrome or not. That has to be said to the patient. And the turnaround time with the FISH or QPCR will be 2 or 3 days max. So the patient will get the report in 2 or 3 days max. And so they will have a 1%.
Okay, you would choose a CVS or amniocentesis in this case. The obstetrician calls you that I have a screen positive result 13 weeks. Should I wait for amniocentesis? Should I go for CVS? What do you, how do you explain the situation to them?
So my choice would be an invasive testing, but I cannot take the decision regarding her pregnancy. So I have to give the option to that female, and she has to take the call.
So, Sona, what is your take on this? CVS or amniocentesis in this situation?
So she's 13 weeks, so it's better we can go for CVS.
Okay. Is CVS having some advantage? Is there some pros or cons associated with CVS that you should tell the patient?
So risk of miscarriage will be 1%. So there can be there will be confusion with placental mosaicism, which is being seen in cases of CVS. So if patient wants to opt for amniocentesis, they can go for amniocentesis because risk of miscarriage will be 0.1%, and there will be no risk of placental mosaicism as well.
Malti, madam, there's quite an obsession regarding the miscarriage risk that is associated, because traditionally we have been told that 1% or 2%, 1% for amnio, 2% for CVS. Do actually this much miscarriage happen in real practice? No.
We have not seen any miscarriages following CVS or amnio. At the most, we've seen few cases of PPRM following amniocentesis. CVS is very safe. If the placenta is anterior, I think it's almost 0%.
So
But as
there is a
Dr.
yes,
said,
yes, ma'am.
we had a patient with CVS where the fish was normal, and we
Mm-hmm.
got a culture report of mosaic of chromosome 3.
Okay.
So the genetic is not sure whether it's a placental mosaicism or is a true mosaicism. So that
Mhm.
patient, we had to repeat amniocentesis. That's the only problem which we faced, I think, over 1,000 cases. But very rarely also we've seen placental mosaicism. Very rare.
All right.
Dr.
So you have a
Malti,
yes,
Dr.
ma'am,
Sinesh or
please.
Dr. Malti, if we ask for an amniocentesis and a fish, we get the reports within 3 days. So
Yeah.
can we go ahead with the fish reports, or should we really wait for another 2 to 3 weeks to get the complete amniocentesis report? Do we get any changes in the report?
Generally, there are no changes. Suppose if fish shows trisomy 21, it's 100% 21. But sometimes we may pick up mosaic. So in such patients, we tell the patient to wait. And sex chromosome abnormalities also are picked up in the initial fish report. Generally, we have not seen any discrepancy regarding abnormality. Suppose it's trisomy 21, culture also will show trisomy 21. But sometimes we've seen fish being normal and culture picking up trisomy 21.
Okay.
So, but if it's abnormal, it is 100% abnormal, I think. Because we usually tell them that's better to terminate. Because we had one patient who came in from Chennai showing fish showing sex chromosome abnormality at 20 weeks. They said we will not terminate the pregnancy because we have to wait for the culture, the karyotyping. The KT also showed a Klinefelter syndrome. So by the time the Klinefelter, the report was ready, she was almost 28 weeks. So they said we cannot terminate. Go to IOG for the meeting which we have. And IOG people said, no, it's not a lethal anomaly. It's better to continue. So patient came to Trichy at 34 weeks, completely confused, completely disturbed. So I think when a fish says sex chromosome abnormality, why not? Because you've reached the borderline of 20 weeks. You know the KT is going to take another 3 weeks, and our MTP rules is only till 20. So I think depending on the gestation age, we have to take a call many times. If I was there at 20 weeks seeing a sex chromosome abnormality in the initial fish, I would definitely say terminate. I will not say wait for 23 or 24 weeks and wait, go to the government hospital HOD, have a meeting, and then go to the court. I think it's too mentally disturbing.
Difficult scenarios. Yeah, true. So
That's
the patient point of view
case.
also, yeah.
Yes.
Yes.
From the patient point of view, they're extremely disturbed because of this problem.
So because of shortage of time, I quickly go on to this case this case, because this is something that the attitude and the practice should change in the perinatal scenario. So here we have a 29-year-old primary gravida who has come for an NT scan at 12 weeks and 6 days. And we can see that the NT is about 3.4 millimeters. So Reshma, in the scenario, what would be the next test, or what would be your next step of management?
Sir, increased NT when the nasal bone, irrespective of the nasal bone present or absent, it's better to go for the invasive testing, because increased
So as
NT,
for you, what is increased NT? So there are several definitions that we have for increased NT, such as traditionally we thought it's more than 3.5, then we have more than 99 centile. Some people say more than 3 mm. So what is, I want to ask each panelist, starting with Reshma, what do you think is increased NT?
NT is specific for that particular CRL, sir.
Right.
So we have the normograms for starting from the CRL of 45 till the 84.
Okay.
The
Excellent.
mean will be around 1.6. Starting with the 45 to the max, usually 3 mm. More than 3 mm, we take it as a cutoff for the
increased NT. So what about, say,
yes.
you get a NT of 2.7 millimeters at 11 plus 3 weeks? You still take it as normal or increased?
When you put the CRL and the NT, it show that the software shows a chart. If it is more than 95th centile for that particular CRL, then that's when we consider it as increased NT.
So traditionally we had this definition, this cutoff for increased NT, that is 3.5 millimeter. We were in an era of karyotype. That was the only available test during that time. And major chromosomal aneuploidies were there when NT was more than 3.5 mm, with the understanding that it is more than 99 centile across 11 to 13 plus 6 weeks. Later on, we had more advanced genomic tests, which found that there are abnormalities between 3 to 3.5 millimeter, and therefore 3 mm cutoff can also be taken. And that is again an individual practice. So Malti Madam, what's your input on this?
I think we go by centile based on the CRL. Anything more than 95th centile, we will correlate with an increased NT, because very often they say 2.2.
Yes.
Yeah, they say 2.2, the NT is increased. What to do? I think centile is
All
very, very important. So I always tell them, oh, we put them in the centile of our FMF software and arrive at a diagnosis.
So Sonam, in this case, NT is 3.4 millimeter. The NT is 3.4. Nasal bone is present. There are no structural anomalies. We all know 95% of people know karyotype, but is there a role of going for a higher test in this scenario, like a chromosomal microarray or newer tests, which all laboratories are coming and meeting us, and the obstetrician whole exome sequencing? So what would you choose in this particular case?
So we'll choose for QFPCR and chromosomal microarray. I mean, karyotype and chromosomal microarray. So because chromosomal microarray helps us to identify microdeletions, duplications as well, with copy number variants up to 5 KB, MB, 5 MB, sorry.
So you would offer
20 to 200 KB, sir.
So you meant to say you will choose a QFPCR with karyotype in this approach?
Karyotype with CMA, sir. Chromosomal microarray.
Okay, you would go for a chromosomal microarray. Malti madam, is this your approach also?
Yes, microarray, definitely.
Microarray. So no more karyotype, right? When there is a structural anomaly, you pointed out a lot of structural anomalies in your NT scan presentation. NT is a powerful marker of structural anomalies. So no more thinking just about karyotype between 11 to 13 plus 6 weeks. We have to go for additional tests such as chromosomal microarray and whole exome sequencing. There was this wonderful, publication which showed the presence of copy number variations that only a chromosomal microarray can pick up. And they found that there were 6.5% fetuses with a pathological copy number variation when the NT was between 3 to 3.4 millimeters. And then there were a lot of other publications which also showed the value of exome sequencing for this. So I think for the obstetricians, it's often confusing whether to go for a karyotype or a CMA or a whole exome sequencing, and then they can take the help of a clinical geneticist in this scenario, right? Kundavi madam, what do you have to say about this?
Exome sequencing is advised, I thought it's more informative compared to microarray. So definitely we go with the genetic opinion, but don't you think that exome sequencing is more informative compared to microarray?
So yes, your answer is very, your question is very pertinent. If we ask the clinical geneticist, I think they will go for a stepwise approach. They will ask first to do a karyotype, then a chromosomal microarray, and finally a whole genome sequencing, right? We don't have time for all this during pregnancy. And so most of the obstetricians are really having short resources. So I think we can definitely go for a rapid test, such as QFPCR or FISH with chromosomal microarray, because universally doing whole exome sequencing can pick up variants of uncertain significance, which is very difficult to explain to the couple.
Dangerous.
Yeah. So do a microarray, then maybe consult the clinical geneticist as to what is the best scenario in this particular case. So the basic message that I want to drive through this particular case is maybe karyotype is getting obsolete in the current practice, in the current perinatal practice, and it's high time that we consider higher tests such as a chromosomal microarray, and even consult the clinical geneticist or a fetal medicine specialist about whether we should go for a exome sequencing, because just from this table we can see that they can pick up much more things which a karyotype can fail to pick up. Even in my center, in a presentation that I did 2 months back, for cases of increased NT, 14 cases which had increased NT during a period of 14 during a 2-year period time, and the patient actually accepted to do. We found that there were cases with pathogenic variant in about 4 of these cases. That is, of 14 cases, 4 cases had pathogenic variants. Pathogenic variants means neonates can be born with abnormalities, they can have abnormal neurodevelopment, etc. So this all could have been missed if we had just gone for a karyotype, right? What, Malti madam, what do you have to tell about all this?
Actually, we had a very bitter experience. I think Revati remembers. We had a patient with increased NT. We did a microarray. Microarray was normal. Anomaly scan was normal. You remember, Revati? And promptly 28 weeks, the patient went in for a skeletal dysplasia. From then, we have started trying to, we usually tell the patient that do a fetal DNA storage, because the likelihood of skeletal dysplasia also can occur with an increased NT. So that was a lesson which we learned. But the problem is, when we offer whole exome sequencing, it's extremely expensive, costing somewhere around 25 to 30,000 rupees. So our patients are really jittery when they listen to that. It may cost around 25 to 30 along with the microarray, maybe 10,000 more. So I don't know, we have to balance the risk of cost effectiveness, but we can do a fetal DNA storage. If necessary, later we can do exome sequencing on that. So that will be, I think, better option. What do you think, Dr. Sunil? Depends on the place where you practice.
Yeah, that is very important. The financial resources that are available for disposal basically determines the kind of obstetric and fetal medicine practice you do. So I think we are running short of time.
One question, Dr. Senish and Dr. Malti, what's the advantage for us to know the storage of the fetal DNA? Is it for the next future pregnancies?
So when we store fetal DNA with a laboratory, they do it for 5 years. Now, when a major anomaly is diagnosed during your anomaly scan, the patients are already, they are shocked and they are in a state of grief. So they are less likely to accept a higher test, such as whole exome sequencing at that point. So it is a good practice to offer a amniocentesis stored DNA, because it's storing DNA is hardly about 1,000 or 2,000 rupees. Later on, before next pregnancy, when they come back to you, and they want to know what are the chances of having the same anomaly in the next pregnancy. So at that point, we can have a joint counseling with the clinical geneticist, and then we have the fetal DNA at that point to go for a higher test at that point, which we saw from the tables have picked up much more than a traditional karyotype-based approach. Malti, madam, what do you have to say about that?
Yeah, same way, same. I think when you have a suspicion, it's always better to store the DNA, because you can always look for other things when you have a suspicion. But initially, when you tell the cost, the only thing which I'm facing is the cost factor. And when you have a suspicion, I think DNA storage costs somewhere around 2,000 rupees. And you always convince the patient that for further investigation, that may be necessary, either for the present pregnancy or future pregnancies. It can be either way.
Right.
Do all babies need to send for autopsy when you have such abnormalities seen?
Yes.
Autopsy is the gold standard investigation to confirm the findings that you got in your prenatal ultrasound. And sadly, its uptake is very less. I practice in a place where the acceptance is very poor because of religious and ethical concerns. But whenever there is a major anomaly diagnosed prenatally, I would like to say that autopsy is a gold standard investigation in that case. It throws much more information that anything can be done. And it would be, highly advisable to do a genetic testing following fetal autopsy. So whenever a patient can accept, yes, we have to offer fetal autopsy in those cases.
What about the skin biopsies or something where people talk about?
Malti madam can throw more light, because she is...
Especially, when we have, nil LICA, for example, a polycystic kidneys, nil LICA, we're not able to approach a cord. In such patients, we tell the patient to bring the fetus, do a tissue biopsy, take about 4 or 5 biopsies, send for exome sequencing. Actually, we've done it on dried cord also. We had one patient who told me that she had a dried cord at home, recurrent, the same thing, recurrent skeletal dysplasia. She brought the dried cord from home, and we did an exome sequencing, and she tested positive for primordial dwarfism. So when you don't have access, suppose the cord is deep down, you're not able to access the cord or any other, for blood sampling, then you can tell the patient, bring the fetus, and we do a tissue biopsy and send it for exome. That also can be done. We've done it especially in women in fetuses with anhydramnios, where the cord is not accessible in such conditions. I think there's a question from Dr. Devasmita. Increase NT and exome, rhasopathies, GSG, skeletal dysplasia, these gray areas. You want to take that? NT and exome. Yeah. Have you seen rhasopathies with increased NT?
In my experience, rhasopathies have been fewer, but increased NT, the approach that I offer in my center is to go for a karyotype with whole exome sequencing, because whole exome sequencing has a certain disadvantage. It is slightly, not so capable of picking major aneuploidies. And the information that you can get from this combination in my practice has been much, much, much great. And various single gene and autosomal recessive disorders we were able to pick up. So I think that would also include rhasopathies and many other, conditions which can have pathogenic variants. So I think sooner or later, the cost of all these tests is going to come down, and we would be able to offer these tests to almost all women who, need that because of a particular reason, such as increased NT.
Yes.
So I think we'll wind up this session where I want, Reshma or Sonam and Revati to give one particular message to everyone, to the audience here regarding first trimester scanning and screening. One important message that you want to give to each of them?
Yeah.
Take home message. We will start with Reshma.
Reshma?
Am I audible?
Yeah, you are.
So currently in this this place I'm working, I see even now the triple test is being done. So it's obsolete and it should not be done, and it has it should not be considered at all in the first place, even if it is done for the risk calculation also. So that is something it has to come into the clinical scenario and the practical aspects.
So the important point is that a woman has not undergone a first trimester screening. If she directly lands up in second trimester before 21 weeks, we can offer a second trimester quadruple test instead of a triple test, right? The difference between these two tests is hardly about 150, 200 rupees. So it is high time that the laboratories themselves stop offering triple test. It's an outdated test. Very important message from you. Thank you so much. Next, Sonam.
So the place I'm working over here, people don't even do dual markers. So I just want to say universal screening is very important. It should be done ideally between 11 to 13.6 weeks of gestation. And management should also be protocol-based management. And if any doubt is there, they should consult the fetal medicine specialist.
Thank you. Thank you so much. So Reshma, you have to add, give a take-home message. Revati, sorry. Pardon me.
Sir, my thing is like the patient is not actually properly educated that it is only a screening test, first of all. So they have to be educated that it is only a screening test and it has got a certain sensitivity, and it is not a proof that the baby is going to be structurally also normal. What happens? The patient comes with a normal combined screening test and they go in for a second trimester, mid-trimester anomaly scan. If you find any anomaly, the patient just panics like anything. They are telling that we have done everything you have told so far, and now you're telling me that there is an anomaly in the scan. So they have to be previously, they have to be prior told that this is not the proof that the baby is going to be absolutely normal. So that has to be
as we saw in the second case. So universal screening at 11 to 13 plus 6 weeks, universal good quality scan, universal offering of Down syndrome screening, and as Ponmori told, universal offering of preeclampsia screening should be the target that we all obstetricians should aim for, right? So thank you so much, all the
Dr.
panelists.
Sinish, one message. I think the obstetrician also should know what to look for and what to ask for in case, the basic things I think we should know.
Correct. So in that scenario, we should take the help of all the wonderful fetal medicine specialists that we have around, the clinical geneticists, the pediatric cardiologists, etc. And we all should work as a team to give the best care to our antenatal woman. So thank you all moderators. Thank you, Kundavi madam. Thank you, Reshma, Sonam, Revati, and thank you, Malati madam, for this wonderful discussion that we had. Thank you so much.
Thank you, sir.
Thank you, Dr. Sanish. I think it was a wonderful, amazing, awesome panel. I think all of you would agree. Thank you very much for throwing a lot of insights on many new things. I think I'm sure the audience are going to be, sort of benefited by this in their day-to-day practice. Thank you, Dr. Kundavi, Dr. Reshma, Revati, and Dr. Sonam. Madam Revati, madam, you want to add something?
Thank you very much. It was a wonderful panel. Main thing is the standardization of the laboratory. That is very important. Even for anemia, that is very important. We get wrong results. So it's okay. So that is very important. And case-based discussion, it is really a nice one and very interesting. Such problems we do meet with in our day-to-day practice also, whether to go for this or not, and if she comes with this problem, how to manage and all those things. And really, it was a wonderful thing, Dr. Sinish. Nice. Thank you.
Thank you very much. Dr. Radhika, you want to wind up? Next webinar will be on November 18th, where we're going to target on second trimester abnormalities. Then we'll go system-wise. So this will run for 1 year. We'll include neuro, cardio, and more of Dr. Sinish will come. And many fetal medicine specialists will be included in the webinar. Thank you very much for joining. Dr. Radhika.
Thank you, ma'am.
Thank you. Thank you, ma'am.
Thank you.
Bye.